Hello and welcome to the Psychoimmunology Summit 2018. Thank you so much for joining us. I'm your host, Dr. Eva, and my guest for this session is Dr. Kate Truitt. Dr. Kate is a licensed clinical psychologist and has been recognized for outstanding patient care and small business practices in Pasadena, California for multiple years now. And Dr. Kate is committed to understanding the brain's ability to transcend and transform the complex and beautiful relationship between nature and nurture. Utilizing her training as a neuroscientist and a clinical psychologist, along with her MBA in healthcare administration, Dr. Kate has passionately dedicated her life to advancing the treatment of trauma and stress-related disorders. Dr. Kate is a certified clinical treatment professional, as well as a certified Havening techniques practitioner and a trainer. So Dr. Kate, welcome to the Psychoimmunology Summit. It's so great to have you with us. I'm really, really excited for this conversation with you.
Well, thanks for having me, Eva. I'm really excited to talk about neuroscience and autoimmune disorders and really at the core trauma and how it has such an amazing and heartbreaking capacity to completely derail our body's ability to function fully.
Well, absolutely, because we talk with the events that I do in a lot of sessions. In fact, we have talked about the impact of trauma on our physical health, whether it's microbiome or sort of other aspects of our physical self. So I am keen for people to sort of have a better understanding on what we're dealing with. And I know you've got such a huge passion for neuroscience, and we promise not to be too overwhelming with neuroscience, but at the same time, I think understanding is quite powerful. It empowers people. So, but before we go into all that, I know you have a bit of an personal experience with autoimmunity. So, are you okay to share that with us before we go into the neuroscience of trauma?
Absolutely, it informs my interest. I think it's very human of us to want to better understand our own experiences and to utilize that information to make sense of the world. And so my personal experiences with autoimmune disorders have played a role in why I ended up studying trauma so intensely. I was always a sickly child. We didn't quite understand why. I always had severe gastrointestinal difficulties. To this day, I still do. I have very severe celiac, where if I actually have any gluten, I have seizures. I have a full autonomic nervous system shutdown, and I end up in the hospital. And so it goes beyond that leaky gut gastrointestinal disturbance for me, where it actually attacks my brain. And that definitely is tied to the difficulties and the stress that I experienced in my childhood and being chronically ill. And I also have something called Raynaud's, which I'm sure you're familiar with what that is, which is an impaired circulation. As I started to explore and understand more about science and the brain and the mind and body, really helped me identify the positive and powerful shifts that I could make. And I was working with an amazing endocrinologist and sliding into, I had hypothyroid, and I was actually able to correct and get my system back into balance by doing trauma work. And I think that's really the power of understanding the mind-body connection, because we can transform what we can do. And the new technology that's out there today, the new treatments and options that are available for people, really make it easy and accessible.
Absolutely. And I tell you what, thank you for sharing that. But yeah, very similarly, and a lot of viewers will know my story, but I, a long time ago, suffered with chronic fatigue syndrome. And I also had Hashimoto's thyroiditis, and resolving trauma played such a massive role ultimately in my recovery. And I hear what you're saying about gluten. A lot of people will have neurological symptoms as a result of eating gluten and being contaminated, having the food contaminated with it. But to me, obviously, gluten was an issue, but even eliminating that, it just didn't really get me as far as I needed to go. And it was the trauma work and resolving all the early childhood trauma, in my case, that actually helped me heal. So that's why I'm so hugely passionate about it. And so it's interesting to know that you've had a sort of similar experience in that respect. So perhaps we could start with defining trauma and sort of over this and other events, we obviously talk about trauma a lot, as I said, and we sort of defined it in a sort of variety of different ways. But I'm just kind of after maybe defining trauma from the sort of neuroscience perspective, if you will.
Absolutely. And just to speak to what you're just sharing there, I had encephalitis, which is a brain virus, for about 18 months, and consequently chronic fatigue. And so I would crawl my way to the shower and sit in the shower. And the exhaustion and literally crawling across the floor because I was too tired to walk to get to the shower would require a 15-minute rest before I could then proceed to wash my hair, whatever it might be. So even that is traumatic. So when we look at the notion of trauma from a neuroscientific point of view, we're really targeting specifically the part of the brain, the amygdala, that encodes the trauma and all the resulting impacts from that moment of encoding. And when something's encoded, what that means electrochemically is that something called a hyper gamma wave has been released into our electrochemical system. And that because of these specific situations, so there's criteria that have to be met, that it has to be a moment of inescapability. We cannot get out of it. So our system is holding on to this going, if we survive this, we're going to remember this forever. It's usually tied to an inherent threat stimuli that we're all as humans born with. So if you have a child who's an infant and you ask them, or you have them crawling across a ledge and there's plexiglass, so the ledge continues, but visually it looks like the ledge will drop down and they feel like they'll crawl over the ledge. They'll actually stop. And that's because as a species, we're hardwired not to go over cliffs. And so these hardwired experiences can then be ignited in our present day life. And that's something that gets encoded. And largely that amygdala is primal. And so in our day-to-day life, we have a lot of experiences that our system simply wasn't designed to experience. And that's where the confusion occurs, and we start to see people who have encoded experiences that are small t, big T trauma. So, big T would be, if I'm in California, so if an earthquake occurred right now and I couldn't get out, that would be a pretty big T trauma. A small t is being bullied in a sandbox and a fear of rejection from peers or whatever it might be. And so our brain stops being able to differentiate it, and instead with that hyper gamma wave just latches onto the experience and says, this experience from here on out is going to remind me that I am going to die. And that generates experiences and traumatic reactions across the lifespan until that specific experience is healed. And so it's insidious when these experiences encode in our brain. And part of that is the amygdala is tied to every major organ system in our body. And so when we encode a trauma, the amygdala is still there driving our information processing. I think that's one of the greatest things, that my most empowering pieces of data to give my patients and for our viewers to hear as we're talking today is we do things that feel crazy and they're not. It's our little amygdala going, in this moment there's a threat. And so I just kind of gave a very long-winded explanation, but the idea of trauma is not just that encoding moment. It's all the neural networks that develop out from that moment. And that's what brings in and comes into our present moment and causes so much disturbance and distress, whether it be autoimmune dysfunction, whether it be nightmares, panic attacks. Are you familiar with ACEs, the Adverse Childhood Events Study, Folletti and Kaiser?
Yeah.
Anybody who had 2 or more ACEs had a 70 to 80% greater likelihood of being hospitalized for an autoimmune disorder. Mm-hmm. Let that sink in. Yeah. So,
I often quote that very study, actually. And yes, we have talked about ACEs on a number of occasions here. But that is, that's huge when you really think about it, because show me anybody who can go through their childhood not being traumatized in any way, right? So that's why it's so big.
Yeah. And it's not and I think what people lose sight of, and these are conversations I have with my patients, is you can have wonderful caregivers and still have really difficult experiences. One does not remove the other. And if those difficult experiences are still hanging out, causing disruption, then it's important to take some time and heal that, because it's played a role in the development of yourself, of your mind and your body.
Yeah, absolutely. Exactly. And so you sort of started talking about some of the conditions that have to be met in order for the trauma to be, as we say, coded in the brain. So maybe you can actually expand on that, because that could be interesting to people, because we could have, obviously, and that has been studied, and that obviously most people will know, that you could have the same thing happen to two different individuals, and one of them will be traumatized and the other won't.
Absolutely. And I think that's where it starts to get confusing for people as well. The Rudins have coined the idea of Emily, which is a really wonderful theoretical construct for what has to happen in an encoding moment. The idea is that an event has to happen, and that makes sense. Something has to have happened. And that event has to have meaning. And meaning is really about attachment. At our core, we are, as a species attachment-based. We need community. We need tribe. We need each other to survive. If we go back to that primal amygdala experience, when we're cave people running around in the fields, if we came across a giant tiger or a lion in the field and we're alone, we're not going to do so great. We're dinner. But if we're out in the field and we have a tribe of people and we come across a lion, our chances of survival are significantly greater. And so at the very core, meaning and attachment go hand in hand, and that attachment is based on survival. We need others to survive. So an event has to happen. That event has to have some sort of meaning, and whether it could be attachment to my own life, attachment to somebody else's life, attachment to an item that's really significant. Perhaps somebody's passed on. I'm a widow, and so I have certain items that are extremely important to me that were really connected to my late husband, and so I really hold on tightly to those and give a lot of meaning to those. So that's attachment based. And then so once we have our meaning and we have the event, then there's something called the landscape. And that landscape is basically how our brain is functioning at any given moment. Could be woke up in the morning feeling great, and then you're on your way to the office and you spill coffee on your blouse, and all of a sudden your landscape's a little more vulnerable because, oh man, you're meeting with the board of directors today and you've got a huge coffee stain on your white blouse. So in that moment, once that cortisol shows up, your landscape's a little more vulnerable. When we speak about ACEs, we know that individuals, the more ACEs they have, the more vulnerable their landscape. So if you have 2 ACEs versus 8 ACEs, your landscape has developed across the course of your lifetime with greater levels of cortisol. You'll have more cortisol receptors in your system, which means your brain is actually going to soak up cortisol and have a greater reaction to it when that cortisol is released. It means that certain parts of your brain are functioning in ways that may not be preferable for you to be your best self. So the landscape is electrochemical, it's physiological, it's executive functioning, information processing, it's all of those factors. And if that landscape is vulnerable enough, only then will the trauma encode. To speak to your point, but that's why some people who are at 9/11 didn't have PTSD. They were able to connect with their tribe. It was a very big event, but they knew that they were going to be safe. And people showed up and held them and created space for them, and their landscapes were such that it wasn't permissive for encoding. And the final thing that has to occur, which is what releases that hypergamma wave, is a feeling of inescapability. If we cannot get out of the moment, if our system goes, this is it, we're done. Even if we do survive, if there's a moment where the system says, I am powerless, I am helpless, I am hopeless, I am stuck, I am trapped, that's that hypergamma wave release. And that's when there's little neurons in our amygdala on a very specific nucleus. The lateral nucleus will perk up and go, we're going to remember this forever, because if we survive, we're always going to know that this is something that could kill us. And the heartbreaking side effect of that is those neurons who've encoded those moments, say there's a moment of being powerless, a perpetrator, somebody's being assaulted. In that powerless moment, the system links into that and will start to build a neural network around the idea of that person being powerless. And I think that's one of the most insidious impacts of trauma that people don't talk about, because it's not just the moment of encoding. It's not just, oh, a car backfires, I'm a veteran, it reminds me of a gunshot and I hit the ground. It's what does it mean about me that I just hit the ground? What is my self-concept that I am weak or helpless or vulnerable? And how do I navigate living with that core self-defining construct? I think Emily is a really way to look at these encoding moments, and when we do our own assessment of things that might be ACEs, so to speak, are those moments there? Was the event? Was there meaning of attachment or loss of attachment? Were we vulnerable? And was it inescapable? And then the easy litmus test that I have my patients do is, when you think about it, does it still feel gross? Do you still go, ooh, I don't like that? Okay, that's Amy. So that's the simple way to define it. If you pull it up and your brain goes, I really don't like it, that means that's something that you can do some empowered healing around and change the way your brain's functioning.
Yeah, I thank you first of all, for this excellent explanation of this. And I love that. That's really brilliant. So you mentioned Amy. Talk more about Amy.
Yes. Yeah, one of my goals as a clinician, and so I mentioned I was widowed, I had PTSD, I've had a pretty fascinating journey of opportunities for a lot of self-growth and overcoming a lot of stress and trauma. And one of the things that really hit me hard when I was living with PTSD for 5 years was that I was a trauma specialist. I'd been studying trauma since 2000, working in rat labs, looking at information processing in rats and a taste aversion paradigm, basically. And even knowing everything I knew, I felt completely crazy because the PTSD would hijack me and I felt so lost. And so I shut down my clinical practice, and it was actually when I found havening. And I just, on a total moment of hope, flew out to New York, hoping I could get my life back. And Stephen Rudin, one of the founders, worked with me and did incredible work with me. And I got my life back, which is why I'm a trainer and going nationwide now doing what I'm doing. But one of the things that really hit me really hard was I understood the amygdala down to the key little nuclei. I understood the receptors. I understood the little calcium channels, but I still felt crazy. And so in my own healing process, I started to differentiate Amy, the amygdala, and Kate, the human being. And I go, Amy's having a really hard day. Amy's freaked out. Amy's doing a really crazy thing right now. And Kate doesn't have the amount of control she would prefer to have right now. But she knows that Amy feels like we're going to die, so Kate can be compassionate for Amy, rather than be really vicious and mean to Kate. And that cognitive shift created an opening for self-compassion. So when we have Amy, we can realize that Amy's only job is to keep us alive, and she's not very wise sometimes. And then when we can separate it and go, I'm not the one who's broken, I'm not crazy, I'm not powerless. It's just Amy thinks that we're really going to die right now, or somebody's going to die. My case was somebody was going to die. That was my trauma, my PTSD. And so I can move into self-compassion and kind of hold space for Amy. And just imagine, okay, I'm wrapping her in a little fluffy blanket because she's really scared. And that's been one of the most simple and most powerful clinical tools that I teach to my delegates, the doctors and clinicians that I train, and also to my patients. We create room for Amy, because when Amy has space to heal, she'll heal. But if we're just beating her up all the time, well, as we know, we're just dumping cortisol and stress onto her. We're going to make her freaked out. She's not going to be having a good day at all. That's a long-winded explanation of Amy, but it's such an important concept.
It is. And you know, it's extremely powerful. It's not complicated, but it is extremely powerful. And it almost, it gets people off the hook. And so many people beat themselves up for having certain behavioral responses and thinking that they are just la, and there's just seriously something wrong with them. So this is such a beautiful way of just separating the two, and actually the self-compassion, and I absolutely love that, and that is truly, truly powerful. So thank you for sharing that, because yes, I've heard you mention this before, and so I obviously knew there was a good reason behind this, and it's I believe it's super helpful for people to approach it in that way. So talk to us a little bit more about the sort of different hormonal changes that go on in the body when a traumatic event occurs.
Well, if we keep in mind that our system always wants to be balanced. Our system always wants to be in homeostasis. So it was always seeking to return to its optimum state. And in a healthy, high-functioning, non-traumatized, sorry, I keep doing quotes, but non-traumatized body, like we were saying, we don't really know many people who don't have just a couple encoded back there, but those who haven't gone over to the complicated side of things, so to speak, the system will always be bringing us back. And when we look at what starts to happen with trauma is anytime one of those encoded experiences back here in Amy gets triggered, she releases one of several different reactions. And we're all familiar, fight, flight, or freeze. And then there's thanatosis or defensive rage. Each of those has a very specific physiological representation in the body. So if she goes into freeze, we know, okay, if you imagine freeze state, your breath slows down, heart rate calms, we're going very, very still. We don't want a perpetrator or a predator to see us. If we go into flight or fight, we definitely have a change in our muscles. We have a change in the heart rate and the breath, and all of those coincidingly have hormonal shifts. I think one of the most powerful hormonal shifts that we know now is that as the levels of cortisol in the system continue to increase, our brain will actually coincidingly make more and more glucocorticoid receptors. And if you think about that, it's smart because the system's going, we're going to need more. But what that means counterintuitively, and this really befuddled the scientific community for decades, is that when cortisol is released into the system, if we do what's called a cortisol swab in the mouth of somebody who has a lot of glucocorticoid receptors and they're on a stress test, their cortisol levels will actually be lower than somebody who doesn't have a high number of glucocorticoid receptors, or to speak what we're speaking about, say a significant number of ACEs. So somebody with one ACE will have fewer glucocorticoid receptors than somebody with 3. And that follows us across the lifespan. And what that looks like in terms of our emotional or psychological functioning is that person's more likely to have chronic depression. That person's more likely to have anxiety because their system has developed a new baseline informed heavily by Amy that says we need more stress to be at our baseline and be able to survive. So that same ACEs study, they identified that 70% of people with chronic long-term depression have 4 or more ACEs. And we've actually seen, these are a large number of my Hashimoto's patients. I work closely with an endocrinologist here in town who, once we start treating those ACEs, their Hashimoto's frequently will get significantly better, or even resolve itself. And she'll send patients to me prior to going on the medication. We know once we start taking the thyroid meds, the system readjusts itself to those medications. And so it's very, very hard to get off those meds once they start. But if we cannot frequently resolve, and that's what happened with me, we can resolve the Hashimoto's because we're treating what's going on and driving the symptom presentation. So the hormonal shifts go along with that system constantly trying to find that balance. And then some vagus nerve engagement back here where Amy's just going, okay, we got to prepare for this. And then we start getting stuck in it. And depending on how that version presents for somebody, they can be in hyperarousal chronically, hypoarousal chronically, or a lot of people cycle in and out of the two. So chronic fatigue is chronic hypoarousal. And is that how it felt? Just chronically when you were struggling with that?
For sure, yes. So obviously, all that said, right, people go through those traumatic experiences. They can't necessarily help it because most of it actually happens to us earlier in life when we can't just stand up for ourselves or whatever else, or even recognize that things are happening and we're taking it on board in that way. And so, of course, it's all about sort of empowerment and giving people hope that they can heal. And even if a person have multiple ACEs, that doesn't mean they're doomed, right? So let's talk a little bit about what actually happens in the brain when we heal the trauma. Because, of course, you and I both know that's perfectly possible to achieve.
Yes, absolutely perfectly possible, and incredibly so. So when we start healing the trauma, it's the way I like to describe it, it's as though the brain starts to get its power back. If we look at something called quantitative EEG or QEEG, what we see in the traumatized brain is that there is a lot of alpha wave functioning in what should be the self-healthy information processing space, and that Amy's getting a lot of energy and pulling a lot of information processing, and she's doing it pretty much on a regular basis once it gets to that point. And so when we start doing the trauma reprocessing, the brain waves shift back into their healthy alignment. And so, we have that idea of cognitive fogginess, poor memory, poor attention, concentration. We have a lot of patients who come in and they're on a lot of different ADHD medications. Well, it turns out they just have a whole lot of trauma. And so we're able to work with the brain to get the brain back into balance. When we're doing that, what we're also witnessing is that the body is getting back into balance as well. If Amy's living in a space of, say, defensive rage, so a lot of people struggle with what's called TMJ, which is where you grind your jaw a lot, or grind your teeth a lot, really tightness in the jaw, and referral pain, neck pain, shoulder pain, and that you walk around carrying that, and then if you've experienced it, you know how it feels, it then starts to go up and you get migraines, and you get all this tension up here. And so as we help Amy heal, the mind and the body then start to say, wait, we're not living in a space of constant threat. And that is a very real body encoding that happens and then releases. And with that release, the rest of the body gets back into alignment. The body gets into alignment. There's a little part of our brain called the insula that is heavily impacted in the traumatized brain. That part of the brain has a strong role in the mind-body relationship. It's what allows us to say, oh, I'm feeling uneasy about this because I have a sensation in my stomach, and my stomach's saying, this feels uncomfortable. That's the insula. And that part of the brain comes back online, and all of a sudden our mind and our body get to have a conversation the way it should, as opposed to living in a world where our body's saying, I'm exhausted, I need to rest, and the brain's saying, I don't care. We are in such a state of adrenaline and threat that you don't get to be exhausted, I'm overriding you. And that's a lot of times what leads to adrenal burnout and chronic fatigue, is that there's no communication between the mind and body. And so when we start to heal Amy, she really wants to feel better. It's just when she's lit up, she doesn't care about quality of life, she only cares about staying alive. And so when we start to heal her, she gets to be like, oh yeah, quality of life matters. Let's start to focus on that. And then our self gets to be in charge and take care of her and the rest of the system.
Yeah, that's great. Yeah, you've got such a great way of explaining things, and that way, even if people don't have great sort of knowledge based in terms of neuroscience, they can still connect with it and understand this, which is wonderful. So, of course, and we mentioned havening techniques already, and we talked about havening techniques. We had a whole session on this by Stephen last year in our first event. And of course, so that's one of the modalities you use. But of course, you had been using other modalities before you even became a Havening practitioner. So you tell us about the sort of different things that you bring together to help people heal their traumas.
And obviously, as a certified trainer and practitioner with Havening, I am a little biased. That being said, I have studied since 2000 trauma. Learned Havening in 2014. So there's a lot of amazing opportunity and data out there for really empowered healing. I think one of the most useful tools is any of these psychosensory techniques, whether it be EMDR, whether it be tapping, whether it be Havening, mindfulness, breath work, meditation. One of my clinicians does trauma-informed yoga. And what all of that is targeting, especially if somebody who has an autoimmune difficulty, is that exact thing that we were just talking about, that mind-body connection, that insula. The more that we can work with what's called the limbic system, which is more of the mammalian brain, the more power we have to get our prefrontal cortex back online. So in trauma, the limbic system, AMI specifically, is really dysregulated. And anytime that we can bring in modalities to help the system, the autonomic nervous system, re-regulate itself, we're helping the limbic system and the amygdala calm down. So mindfulness is fantastic, and it's very easily accessible. Meditation is wonderful. Transcendental meditation particularly focuses on the same mechanism of action as Havening, which is delta waves. Now, a lot of people struggle and drop out of TM because they don't get the immediacy that they would prefer. And at the same time, being able to focus in and do that work, and once you do what's called breaking through to the other side when you're doing TM, it's just transformative in helping the brain shift into a different way of being conscious and present in the world. So all of those modalities are fantastic. And then in our group, so I have a group practice that I run in Pasadena, California, so just outside Los Angeles. And we do everything informed by Havening to help the limbic system, the amygdala, heal. And then we're utilizing our traditional psychotherapy to front load the brain, whether that be, we do a lot of cognitive behavioral therapy, because we're changing the thought processes, the beliefs. We're working with neural networks that have developed across the course of a lifespan that have been formed by Amy. And so we're helping Amy know that there's a different way to look at this. We're changing the cognitive structure of the experience. I myself do a lot of self-compassion work, I'm trained originally in psychodynamics and then moved into what's called dialectical behavioral therapy and cognitive behavioral therapy. So for me, psychodynamic is really more about a core sense of self and presence in the world. And then again, utilizing other modalities to enhance that. I think the recovery process is really about working bottom up. So healing Amy, and top down, healing kind of the self construct to create that new normal of personal empowerment.
I'm with you there. I'm biased myself, and I have to say that Havening is definitely my go-to, one of the sort of top two things that I use with people when it comes to working with trauma. One of the top two modalities that I use, and I had come through different pathways, and I had studied hypnotherapy and NLP and various other things. But the beauty of Havening techniques is that you can actually incorporate all sorts of other tools in with it, and therefore magnify potentially the effect that you're going to have. So whether it's psychodynamics, as you said, Gestalt therapy, transactional analysis, all sorts of approaches that you can actually bring into it, and it actually enhances the process, and it doesn't interfere with it. It enhances it. So, and it enhances the person's experience. And so that's what really is so great. And of course, as we said, it's a psychosensory modality. So there's touch involved, but the person can do it on themselves. And people who have followed me for a while, they will be familiar with it, because I speak about it a lot. I demonstrate it, etc. And so, obviously, that's one of the wonderful modalities that we've got at our disposal. But as you said, there are others. There are so many. And what what is so fantastic these days is that because we have a better understanding of the brain and the neuroscience behind it, the process, we no longer have to spend years and years in therapy. This process can actually be quite quick. That's the beauty as well.
Yes, and that is core to the model that I train my team in. Is we don't want people walking in our office for years. We work with amazing people, don't get me wrong, and I've been part of so many healing journeys that are just humbling, and what has occurred and where those individuals are today. At the same time, the very nature of the fact that they're walking in my door means they're in pain. And so if I want them out there living their life. And so the goal, and I think this really is one of the true gifts of Havening, which does this in a way that I have not experienced, having trained in almost every trauma modality that exists, and having done them all, trying to recover from my own PTSD, is that we not only help the individuals heal through the course of treatment, we teach them in every single session how to do their own work. And I have a great case study for this, where I had a young gentleman who was in a really, really horrible car accident. He couldn't drive. There were several fatalities involved in the car accident. He was terrified to get back in the car. It was maybe 3 sessions to clear out that trauma. He had a strong landscape, very resilient brain. And so we targeted specifically the experience of the accident, the survivor's guilt, and what it meant, and then build some future landscape, positive, resilient components. A year later, he was in another really, really horrible car accident. And I got a call from him. And so called him back, and I checked in, and my anticipation was probably going to need to get him in for a session, because he'd shared with me what happened in the voicemail. And so when I checked in with him, he said, well, I called you right away. And I know you're with patients, so it's 2 hours since I called you. Thanks for getting back to me so quickly. And actually, I sat down, I pulled up the protocols that you'd given me when we terminated. I did all my own work, just like we did in session, and I'm fine. He didn't need an appointment. He was completely fine, because he did what we had done in session. So what he already knew to do, it's just in the course of 3 sessions. My goal was to teach him how to do the work. So, because hard things happen. And so if a hard thing ever happened again, he would have an immediate tool. And he did his own work, and he didn't need an appointment. He's like, you know what? I'm actually great. So no, that gentleman, if we were doing another modality, EMDR is great. I've done EMDR since 2004. That would have taken 9, 10, 12 sessions. And then once the second car accident happened, he probably would have been back in my office. And because his brain still, EMDR targets the anterior cingulate gyrus, Havening targets the amygdala, so we go to the core. And so it's a whole new world for treatment for those of us who are early adopters, because Havening's new, and we, like you just said so beautifully, bring it in to make everything else we do already use with our clients and our patients more effective.
Yeah, that is wonderful that actually people get that tool, and it's there because there's nothing worse than and some people out there still probably do that. Creating the client dependency is just terrible. But unfortunately, a lot of people are put off by the old-fashioned perception or representation of the old style sort of psychoanalysts everybody used to go to back in the 80s, and they would go to them for years on end, 3 times a week, with very little results. Now, I've mentioned this a few times, but I'm really keen for people to understand that this is no longer how it works. And so, yeah, so thank you for sharing that, because this is just another example how quickly even those more complex traumas can be turned around. So that's phenomenal. And thank you so much for all the other examples that you brought into the conversation. And so I actually wanted to ask you, because I know you, I think if I'm not mistaken, you're working on some research. Is that right? Could you actually perhaps tell us a little bit about what you're up to in that respect, without giving too much away, obviously?
Yeah, I was going to say that there's only so much we can share right now. But in the literature and the research that we're doing is focused specifically on what I just described. It's the fact that we are seeing such qualitative, significant shifts, even in a single session of havening. And again, I'm being havening specific, but that's really where I've focused my work as a psychophysiologist researcher now, because it is the most effective thing that I've come across and seen with my patients. And so we see significant changes in heart rate variability and blood pressure. I have one gentleman that I worked with who did blood pressure readings pre-post every time he havened. And it was incredible to see the shifts. And he was referred by his primary doctor after he had a heart attack. And we could see just really measurable, clear, concise changes of how doing the havening work was realigning his body back into its desired homeostasis. And that's really the opportunity here. And so that's where the research is headed. We have some opportunities to do a lot of exciting things, working with now tailoring our intervention specifically to what is not working in the brain, because the brain has grown up and developed around these traumatically encoded experiences. And so not allowed to say a whole lot about that, but we have some new technology that's coming down the line where we can actually track brainwave functioning while we're doing the interventions.
Yeah, and it is obviously, and the more research like that we have, the more we can really take it out there. Because yes, there are still a lot of skeptics out there, but actually all you need to do is just give it a try, and then you'll be sold. Because like I say, it can have such a profound effect so very quickly.
Exactly.
So yeah, so it doesn't actually, for most people, particularly people who are desperate to heal, it doesn't actually take a lot of convincing. But I'm thinking about all the skeptics out there. We obviously need research like that. So that's really super brilliant that you're involved in that. Thank you so much for everything that you shared and the way that you described all of those relationships and all of those actually really complex things that we're talking about here. And you just done it so brilliantly. So really thank you for that. But before we go, I wanted to ask whether there's anything else that you wanted to share with the viewers, anything at all that you want to share.
It's been a joy spending this time with you, and this is something I'm obviously very deeply passionate about, and a lot of it is informed by the pain that I've been through in my journey and just the incredible experiences that I see happening in my office and in my team's offices. And so I just to speak to the skeptics, I get it, and I have a master's in psychophysiology. I'm hard science through and through. And the first time Bill Souls, I was down in Florida, I met him, and he said, "No, Kate, it's this thing. You do this and you do this and this, and things start to get better." And I thought he was absolutely bonkers. And then I started reading Dr. Rudin's book, And the Past is Always Present. I watched the DVDs. And when I started following what he had created, I pulled out, I had a 250-page thesis that I'd written at the time on psychophysiology of information processing and trauma. And I was like flipping through my thesis, my huge bound book, and going, hey, I talk about that study too, and that study, and that study. Not to say that I'm a gold standard or anything, but this is something I had a master's degree in. I have a training company, Viva Excellence. And my trainings, because I'm a licensed mental health practitioner, my trainings are specifically designed for licensed mental health, psychiatric nurses, psychiatrists, stuff like that. So people who are working with deep level trauma. And we're going nationwide. That's a passion project for me. And my team knows that I just pick up and go to cities and do this. And I come back on a Monday, a little worn out, but very excited. And so please feel free to reach out. Kate@drtruitt.com is my clinical email, and otherwise it's Kate@vivaexcellence.com. So excellence, like live your excellence, and help us do this, because it works and it's really powerful.
Wow,
thank you.
That's fantastic. And you know what? I know there are practitioners watching this event. So yeah, absolutely. If you are a practitioner and you maybe you've heard of havening techniques, but you haven't added that modality to your toolkit, then you absolutely should. So thank you so much. I appreciate you being here and sharing everything that you have so generously and so honestly and openly. I thank you for that, because obviously there's a lot of vulnerability there, and you were just really open about it, and so I really want to honor that and appreciate that. And so from everybody here and myself, thank you so much, Kay.
Thank you so much. It was really fun.